Good morning, everybody. Thank you very much for giving us the chance to present at the beginning of Living Donation Week. And I think the topic of this discussion is quite fitting. So today we will be presenting some of the results from our Chinese Health Equity Project. And we will be talking about this project a little bit later in detail. But basically, we are looking at the Chinese-Canadian community and try to see what kind of barriers there might be that may prevent Chinese-Canadian patients with kidney failure to access living donor kidney transplant. And this is a project that is done in a broad collaboration. A number of the collaborators are listed here. We will come back to that as well. And the project, this last phase of the project has been funded by the Kidney Foundation of Canada through a grant to Dr. Samantha Anthony at Sick Kids. And in the last phases of this project, we have been very closely collaborating with Samantha and with many others from UHN and beyond, and we'll see that later. Today, three of us will be presenting on behalf of this group. I will start, it's not necessarily the sequence of presentation. Cindy Wen will present second. She is a fourth-year student from London. She has been with our group, with our Kidney Health and Education Research Group for about 2 years. She spent 2 summers here as an IMS summer undergraduate researcher. And she has been working on this Chinese Health Equity Project, doing both quantitative and qualitative analysis. She will briefly talk about that. The last speaker today will be Dr. Kenneth Fung, who is a professor of psychiatry at UHN. And in addition to his psychiatry world, he is one of the world leaders in cultural psychiatry. I have a few lists. Immediate past president and co-chair of the Education Committee of the Society of the Study of Psychiatry and Culture, immediate past chair of the Transcultural section of the Canadian Psychiatric Association, and a number of similar initiatives. And he is the director of the Asian Initiative in Mental Health program at the Toronto Western Hospital. So he has an extremely broad understanding and experience with culture, medicine, culture, psychiatry, and his input has been quite essential for this work. And I am myself, István Mucsi. I'm a transplant nephrologist at the Ajmera Transplant Center. And I have had an interest in health equity and equitable access to transplant and living donor transplant. So getting to our talk then. So this study fits in a stream of research that we have been doing about health equity. And we like to make the point about the difference between equality and equity, equal or equitable access to transplant or to anything in healthcare and, of course, anything in society. And what this briefly means is that as opposed to providing everybody with the same amount of help, which would be equal, but it may not lead to the desired outcome, in that people may not be able to get to what they want if they only receive equal support from us or from the society. The support that is coming, that is trying to help patients or other members of the society needs to consider the needs of the individuals, and it has to be tailored. And some of us will need more, some of us will need less support and help, some of us will need support in a different way than others to achieve the same goal, to reach the apple or reach whatever objective and goal we have. And of course, this is quite critical in many parts of the world, but probably especially in Canada and in Toronto, because we are a very diverse society, as everybody knows. We cherish this diversity. It's a huge value, I think, and all of us who have the chance to live in a society like that, we learn a lot and benefit a lot from this diversity. And just wanted to point out that about 1/3 of the population of Ontario belong to racialized, culturally diverse, or communities or communities that were born outside of Canada and they have immigrated here in different ways. One of the largest group in this segment of the society is the Chinese Canadian Society, which amounts to close to 1 million people in Ontario alone. And from the perspective of a transplant nephrologist or a nephrologist, it is important to understand that many of these racialized or immigrant groups carry a higher than average risk to develop kidney failure. This is a study from Jeffrey Pearl done a few years ago using data from the Institute of Clinical Evaluative Sciences, looking at the prevalence and incidence of end-stage kidney disease treated with dialysis in Ontario. And what it showed was that compared to people with European background or white individuals, although racialized status wasn't exactly accurately captured here, but people with European background, East Asian, South Asian, Latin American, and African Caribbean communities had a significantly higher risk for higher prevalence for kidney failure, and this was the same for the incidence of end-stage kidney disease. So kidney disease is frequent, and we know that liver disease is more frequent in many of these communities. Liver transplant needs may be more frequent and higher. So it is important to provide appropriate access to this treatment, which is transplant is the best treatment for organ failure and sometimes the only life-saving treatment. Now, of course, equity studies and this inequity studies about access to transplant has been mainly done in the United States. This slide summarizes some trends in access to living donor transplant. And again, for racialized communities there, what this shows is that over the last about 20 years, between 95 and 2014, compared to white patients with kidney failure, Asian and Black patients there had a substantially lower chance to get living donor transplant. And what this graph also shows that throughout the years, this gap between whites and Asian and Black patients has remained actually quite wide, and it hasn't even shown the signs of closing. Is this only in the US? No. We analyzed the data here that we obtained from the Cortris research database that Joe Kim has built over the last many years, looking at about 1,700 people who had been referred here for kidney transplant assessment. We looked at patients who then ended up having a living donor transplant. This is showing the 5 years after the referral. And compared to white individuals, white patients who are depicted with this dotted line, all of the racialized groups that we had information about, South Asians, African Canadian, East Asians, and African Canadians, ACB community members, had a substantially lower chance of getting a living donor transplant, 50 to 60% less chance compared to white patients. This shows up earlier in the transplant journey. People don't have a living donor identified when they come to the transplant assessment, and this has remained very significant both for Asian and ACB patients. At the time of transplant assessment, was this question asked after adjustment for a number of socio-demographic clinical factors, including transplant-related knowledge. So Asian patients were twice less likely compared to whites to have a potential living donor at the time of transplant referral. And people who did not have a living donor candidate identified at the time early on, they pretty much almost never had a living donor transplant. This is basically showing people who had a living donor transplant. Of course, not all of them had a living, people who had a living donor identified, they did not always have a living donor transplant. About half of them went on to have a living donor transplant. But people who did not have a potential candidate at the transplant assessment, they had a number of years afterwards to potentially find a living donor, but actually that didn't happen. So it is important to go out and early. And that's why we launched this study way back in 2014 to look at ethnocultural and racial barriers to transplant. We wanted to identify barriers. And as we were building the program, we were focusing on community engagement. Different communities were involved. And also we are planning, or we have done the first steps of building culturally responsive education materials, but also anti-racism, cultural responsiveness education for professionals. there is a quantitative arm of the study and a qualitative arm. And specifically for the Chinese project, we have been doing this in collaboration. As mentioned in this Kidney Foundation grant, the lead researcher is Dr. Anthony from Sick Kids and some of her team members, a number of co-investigators from UHN and beyond, and from our team. But we are working with physicians outside of UHN who are from the Chinese Canadian community, and we work with the Chinese Renal Association, which is a patient organization working with the Kidney Foundation and a number of other Chinese community organizations. I hand it over to Cindy here, and I will forward your slides, Cindy. Is that okay?
Sounds good. Thank you, Dr. Mukji. So now I'll just be providing a quick overview of the Chinese Health Equity Project and share some of the work I've done over the last 2 summers as a CERP student. Next slide, please. So briefly, the Chinese Health Equity Project, as Dr. Mukji, has been active for the last few years, and it was kind of started with 3 objectives in mind. And these include to improve access to education about kidney health, CKD, and available treatment options. And number 2, to promote equitable access to various kidney disease treatments, and especially LDKT for the Chinese Canadian community. And lastly, to understand Chinese Canadian perspectives and experiences surrounding various issues such as kidney donation, transplantation, and just the healthcare system as a whole. And very briefly, to achieve these objectives, we conducted interviews with Chinese Canadians and discussed different topics. So like I mentioned, kidney health, treatments for kidney disease, along with perspective, experiences, and beliefs surrounding transplantation. And then we analyzed this data in the context of a team setting that was composed of both trained qualitative researchers and undergraduate students with different educational backgrounds. But I'll go into a little bit more detail in the coming slides. So as I mentioned before, I was a CERP student with Dr. Mukji for the last 2 summers, and I have been working on this project for the last 2 years. So here are just some both quantitative and qualitative findings. So for the project, we used mixed methods. So I'm going to focus on the quantitative portion first. So I worked with a cross-sectional convenient sample of adult patients with kidney failure from Toronto, Ontario. These patients completed the Knowledge Assessment of Renal Transplantation, or CART questionnaire, and we collected information on various additional demographic and clinical variables via electronic capture. And then secondary data analysis was performed in STATA using univariable and multivariable regression models that were sequentially adjusted with additional confounders, and multiple imputations were used to address any missingness. For the qualitative portion, as I mentioned, we interviewed self-identified Chinese Canadian adults with and without lived experiences in the nephrology or transplantation pathway. And more specifically, we looked at 5 participant groups, which included general community members, kidney transplant recipients, both DKT and LDKT, living donors, patients on dialysis, and finally, family members or caregivers of patients with kidney disease. These various participant groups were recruited virtually and in person through many different channels using both snowball and propositive sampling. And then we conducted individual, in-depth, semi-structured interviews virtually via the phone or Microsoft Teams. And these interviews were done in English, Mandarin, or Cantonese, depending on participant language preferences. And then finally, the data were analyzed via thematic analysis using both inductive and deductive coding strategies. Next slide, thank you. So before I move on to some of the findings, I just wanted to show some examples of the CART questionnaire and also provide more context behind it. So the CART questionnaire is composed of 15 questions. 10 of them are true and false with the third option of I don't know. And then there are 5 multiple choice questions. This questionnaire was adapted to reflect the local healthcare system and then scored on a range from 0 to 30 points, where higher scores indicate higher levels of KT-related knowledge. And during analysis, the answer choices were dichotomized. So starting off with the quantitative cohort, there were 575 participants in total, but for this analysis, we focused on East Asian and white participants. The total cohort was 36% female, where 7% were East Asian and 40% were white, and the mean age was approximately 58 years. All participant characteristics noted in the table, except for age and sex, were identified to be significantly different between these populations. Next slide, please. So for the regression analysis, I just wanted to focus on the one portion of the multinomial regression models, which is focusing on patients who received a CART score in the lowest tertile, or essentially those with the lowest level of KT-related knowledge. So there were 4 different models that were each sequentially adjusted with additional covariates that were either identified to be significantly different between the groups or also identified and considered based on additional knowledge of the literature and clinical perspectives. Focusing on the univariable model, the relative risk ratio for East Asian participants being in the lowest tertile compared to white participants was 2.56 and was statistically significant. And for the final multivariable model, the relative risk ratio was 2.93, and this was after adjustment for age, gender, immigrant status, education, and Charles Comorbidity Index, and the findings still remain statistically significant. In the qualitative cohort, there were 40 participants, 15 of which were general community members, 12 of which were kidney transplant recipients, 4 were living donors, 6 were patients on dialysis, and 3 were caregivers or family members. The cohort was 50% female and relatively equally divided across the 3 age categories, and most of our interviews were done in the English language. If we move on to the next slide, we also collected some other information, so things like places of birth or religion, but I will not discuss those in depth. Next slide, please. So when speaking to these patients, 3 main factors were identified to be important to consider while developing culturally responsive educational resources. The first one was to provide kidney health content from a preventative perspective with culturally appropriate perspectives and in the relevant languages. So to expand on that, this can include preventative dietary information with advice specific to the Chinese Canadian diet and cuisine, and also just addressing common Confucian and Chinese cultural beliefs in the context of LDKT. And finally, just providing this information in Chinese languages such as Mandarin and Cantonese. Participants also shared that the key messengers of this information should primarily be leaders within the Chinese Canadian community, nephrology professionals, or other Chinese individuals with lived experiences, including living donors, patients, and transplant recipients. It was highly emphasized that information needs to be readily publicized by individuals with authority. So some people mentioned again were healthcare professionals, religious leaders, community organization leaders, and most importantly, what most participants emphasized was that the individual should be of the same ethnocultural background. Third and finally, both traditional and modern knowledge transmission platforms should be employed in the process of knowledge dissemination. So traditional platforms typically include TV, newspaper, radio, and more. And in regards to modern platforms, this includes social media. So for example, Instagram and Facebook, but also platforms that are commonly used in the Chinese Canadian community, such as WeChat. Next slide, please. So the next finding I want to highlight is losing face. This idea kind of encapsulates various experiences, beliefs, and feelings participants shared with us about how KD and KT elicit some concerns for them about 4 different areas. So the first one is negative social perception, loss of positive community reputation, disruption of harmonious relationships, and the potential failures to meet social expectations set by themselves and others. The term losing face directly came from our participants, as seen on the quote on the right, and it dovetails with existing concepts in Chinese and traditional Confucian culture related to dimensions of shame, stigma, guilt, and identity. And although in present day, it may kind of present itself differently within individuals and more implicitly than the traditional form implies, it still is important and influences the way our participants perceive kidney disease and kidney transplant. It is a fluid concept that may affect an individual's willingness to communicate about negative matters of illness, and it depends highly on the personal interpretation of the situation and what they deem quote unquote worthy of losing face over. Next slide, please. So the first subtheme I wanted to highlight was perception that talking about illness is quote unquote shameful. So some participants felt that having chronic illness was a source of quote unquote shame, and information should be kept private at the individual and family or broader social circle level. And the family and broader social circle was known as the greater self. It's a concept in Chinese and traditional Confucian culture. And participants felt that it was important to avoid propagation of information, especially within tight-knit communities such as the Chinese Canadian community and additional community gossip. And they found that this was especially true for having kidney deficiencies, which is kind of a misconception surrounding an idea about kidney disease and health in traditional Chinese culture. And although many participants expressed these views, many still noted that they were comfortable talking about the positive aspects of illness and general health concepts and health maintenance. And I just wanted to make a note that the word shame was enclosed in quotations just due to the reductive nature of the translation from Chinese languages to English. So as a result, we can't be 100% sure that the terminology being provided to us when we're translating back and forth from these languages is accurate and appropriately used as initially the participants intended. Next slide, please. The second subtheme I want to highlight is perception of illness as a personal responsibility. So participants mentioned that losing face kind of changed the way they framed their illness, and it influenced subsequent actionable items or steps they took to manage it. So many felt that it was necessary to keep illness as a personal responsibility to avoid imposing additional discomfort on others and prevent strain on their social relationships. So when taking personal responsibility, there were kind of three main domains or areas of concern that were frequently brought up. The first one was fear of emotional burden on others, so imposing worry or additional guilt, especially when family members were far away. This was especially true for a lot of our immigrant participants. Number two was a fear of having a misperception that by sharing the responsibility of illness, they were requesting for additional material or financial support from others. And then third of all, creating social conflicts within the relationships or experiencing a change in the power dynamics by asking for help. And next slide, please. And the final subtheme is perception of the complexities and consequences of talking about living donation. So many participants pointed to the conversation and experiences of talking about living donation as especially challenging. And there were various perceived complexities throughout all stages of the process and many perceived consequences. And some examples of questions or concerns that kind of came to participants was, with who do I talk about living donation with? Do I do it with friends? Do I do it with family? What is appropriate? They wanted to know when do they have these conversations and how should they actually go about asking these questions? And then another concern was, physical and emotional. What happens to this person who donates to me and myself during the transplant procedure? And what can happen afterwards to our bodies, to our emotional health, to our relationship, and other concerns like that. But overall, these three sub-themes kind of mention different dimensions of losing faith on how participants frame illness, how participants see the responsibility, and also how they choose to communicate about. That's all for me today, so I'll be passing it off to Dr. Fung to finish off this presentation.
Thank you, Cindy. So for this portion, it will be in many ways continuation of what Cindy has presented about the concept of shame among the Chinese population, and from the lens of how it affects not only the individual, but the family, because issues related to face and shame, it's all about interactions, social interactions from a collective point of view. So based on the study, what our team has found is that over and over again, in various different ways, what participants are emphasizing is the importance of the family unit. And so because in Western medicine, oftentimes our thought is kind of you have a patient and you treat the patient. And in a way, you help the patient think about resources all around them, but it's kind of patient-centered care. And from the data, what it clearly shows is that from the community perspective, family is like one of the most important unit of consideration. And that the emphasis on family can be considered an asset in many ways. So we can see the lower right-hand corner that people express how important it is to care for one's family members. and that family unit is a priority in Chinese cultures. And in many ways, we have to put the needs of the family above individual needs. From a cultural perspective, we know that the Chinese culture is a very, very collectivistic. That is kind of a cultural value. And there's then a deep desire to make one's family proud, which is kind of the counterpoint to what is described about shame. It means that one person's failure brings shame and loss of face to an individual, but the whole family. And the flip side, if one person is doing well, it does bring pride to the whole family as well. And there's almost a need to bring the family pride as one of our duties. And there's a deep desire to support one's nuclear family. The word nuclear family does kind of reflect actually a little bit more of a Western concept, because when we say family, there is kind of a concept of nuclear family, especially influenced from Western culture, and especially among immigrant population, where immigrants are often here with the nuclear family, where extended family could be back home. But certainly when we talk about face and shame, there are different layers where it's going to affect the whole thing. I think to understand all of this, everything we've been talking about so far in terms of the importance of face and then shame, and then now we need to consider like the context of where everything is, which is family, is to consider this concept of filial piety. Filial piety, and this is the Chinese word for it. And you can see also this cartoon of like basically a young person carrying on his back the old person, which is kind of, you can see the origin of the character. This one character means filial piety. It's kind of like the son, kind of piggybacking or carrying like the old. This is the half radical for old. So this idea of the youth serving or carrying the older generation, or caring for the old generation, and it's kind of a core concept that you learn when you were, as soon as you learn language. Actually, as soon as you learn language, you kind of become aware of this concept that this is how you live in life, and this is one of the core things to be a person, is to be a true person, that this quality is important. It's less clunky than the English translation filial piety. There's no such thing in actual Chinese language, but this one word, it's already very powerful. And this, I think, has an implication here, because it's kind of that responsibility to make family proud, to care for the family. It's going to be penetrating into here, even though we don't necessarily use that word, but it becomes the scaffolding of thought. So cultural emphasis, then the family is valuable, and then the commitment to family is valuable. Then it becomes a motivation for care and support. So we have two different quotes here that illustrates this point. The quote is kind of long to read, but essentially to hear there's a discussion between a couple, and the woman is kind of saying like, if my parents have a need, my mom probably wouldn't ask me for a kidney because my mom would love me so much. But the partner is kind of saying, well, but if you had known, you would have wanted to do something, right? So there's this discussion about you can see it both ways in this conversation, that first there's a dynamic between the husband and wife, and the wife is kind of concerned for the husband and what it means. So there's a caring in a lateral way in the couple relationship. But what they also have this dialogue is kind of this vertical relationship. Mom would not have asked me, but then I would have wanted to help if you had no mom. So that's a way that the husband can talk to the wife to elicit that kind of family caring, even though initially the wife was also talking about hesitancy. But all this talks about the importance of family consideration and what motivates people. And here on the right, it is a community member talking about just knowing my family has my back no matter what, including kidney transplant, because again, the importance of family. So if family is such a motivation, then why do we see in the slide that amongst all ethnic races in Ontario, like Chinese has the least and East Asian, right? East Asian have the least. It's the idea then, even though family can be such a motivating source that family members are willing to do this, why isn't it happening? Is that kidney disease can really provide a source of challenge for Chinese families. And so these three are the ways that they kind of mutually interact in a way that can manifest as chronic kidney disease, and also the treatment would put stress in the family unit and how we can come to understand it. And we'll look at it deeper. One is that when you have illness, it can disrupt family dynamics and this role that I was just talking about. So the traditional caregiving relationship may be disrupted. And so it has this dialectic that the parents feel uncomfortable in asking children for something. And then the children in turn, or when we say parents and children, it can even be elder and younger generation, depending. In the nuclear families, parent and children, but sometimes it could be wider. It could be an aunt and uncle, it could be a cousin, a nephew. But the kind of older generation will feel uncomfortable asking for younger generation. And the younger generation would also feel uncomfortable asking for the older generation because there's these kind of roles and relationships. So here, a participant says, my mom talk about her role, would think about her role as a mother is not to take away something from kids. And so this would terrify her to do that, right? And here, another participant is saying, well, if my kidney is gone, who's going to take care of children? Like, because my role is to take care of my children. So this idea of being able to fulfill your role, and it's important. So we know that in Chinese culture, and this extends to everything. So from nuclear family, which is kind of parent and child, to extended family, but even to broader, we look at people with broader authority. There is this kind of deference to authority. We tend to listen to authority, but there's this fiduciary relationship. You kind of expect that those in seniors would kind of take care of you, or they should take care of you, right? They ought to take care of you, not you. And then at the same time, you are loyal to them and you try to serve the elder generation too. So there's this kind of relationship. Sometimes younger generation don't understand that, but there's this listening to the older generation that's expected, but we also expect in a way that the older generation, like your mom would take care of you, your boss would take care of you, they have your best interests at heart. So there's this dynamic. So number two is that to talk about illness, it does bring up feelings of negativity. And so it brings up ideas of shame. So the fear that illness is a sign of illness. And the sick person feels responsible then bringing a weakness as well as a perception of illness socially to the family. And so this becomes important because in a collective society, we just talk about how important it is to bring pride. The converse of that, you don't want to be the weakest link. So not only is illness a sense of shame individually, you feel bad about yourself, but you also feel bad in a way for letting the family down because now you're the weakest link. And not only that, there's also a perception of bringing weakness to the family. So there's the actual being the weakest link. You just don't want to be the weakest link in the team. And then the step above that is just kind of, then there's a perception now in the public sphere about weakness in the family. And then, of course, being a collectivistic perspective, there's a lot of care and concern about not wanting family members to be worried about you, because if you ask for something or if you let others know about your illness, you are also asking others to be worried, or you're responsible now for others feeling anxious and worried, right? So, so a participant says family shame should not be made in public. When you're sick, you don't tell others. So I want to put this Chinese saying here. This is the kind of simplified characters, and it's probably the way Mandarin speakers might express it. This is more traditional way, and it's a way that I've been taught since I was young. It's this idea that if you talk about family stuff, that's negative, shameful, ugly. So the translation of this word can be like ugliness, or things that is not a good thing. You generally, as a family, you want to keep it in. It's kind of like what happens in Hollywood stays at Hollywood. Not Hollywood. Did I say Hollywood? No, Las Vegas. Except for Chinese families, it's basically families, right? So what happens in the family stays in the family, right? We don't want to talk about things outside the family. So it's not uncommon that, even if we send in a researcher, you talk with them, they'll give you a completely different picture, because they may think that you are a non-family member. So you wouldn't necessarily talk about everything. So Chinese people are not very good at exposing themselves, especially their shortcomings and weakness, right? So this is the ideal. And so you also saw in Cindy's slide about the importance of gossip. In an ideal society, nobody ever talks about things outside the family. But the truth is, because it's something is so forbidden, that it's not uncommon to have gossip. What we call gossip is, telling each other family health information or spreading family health information. So I would say that ideally it doesn't happen and people fear it, because in reality, the word can easily get out. And once the word gets out, it can easily spread, because it's something that is seen as gossipy. It's not really necessarily seen as, let's spread health information. People might feel like it's kind of gossip, and it can spread. And so the third arm of these interactions is that there's this tremendous then felt burden of asking for kidney for donation and to get treatment. So family members are really concerned by putting a burden on others. And also the act of asking for donation can feel stressful and very uncomfortable as a consequence. So here, there's a discussion here by a member of the community that if my family want to donate, I can accept. And then there's a match. And if they insist, I'm okay with it. But I don't want their life to be affected. That's the preference. I don't want them to sacrifice for me, and I will not ask for it. If they voluntarily offer a donation, I would accept. So this is a very common kind of Chinese thinking. That's why gift giving is such an important thing in East Asian culture. There's a wish that others take care of you. And as I said, there's a wish, especially for a younger generation, that older generation would take care of you. Everything from red pocket money in family homes to at work, you just expect your boss to give you a raise just because of the kindness of their heart. You don't need to ask for it, right? And so to have to ask for something, it's a tough thing because people should just do. So there is this kind of conception here as well, talking about going back to transplant. My brother is probably the most likely option, but never ask him for it because he works in the States, he's single, he's busy, and procedures too invasive. And I can probably tell he might not be that open just from the way we talk. And personally, he's already carrying the weight of all three of us, the whole family. So again, all these family responsibility comes into all kinds of calculations. You always think in terms of families, responsibility, and all different ways of orienting from the family perspective, right? So you can see the concept of shame and loss of faith, yes, but all this is really complicated, embedded in a web of, but he's also taking care of us, and he has all these responsibility as a family member, and he may not really like it. So how do I really ask? And I won't ask for sure, right? So we started with a slide of how family is such an important thing that in reality, we'll give the shirt off our backs for a family member. But then on the other hand, there's this incredible barrier to really ask for it, to really impose this burden on family members. And this need to keep things secret. And then when one word gets out, it becomes hot gossip because it's something that you usually, is a closely guarded secret usually, like health. So it's just kind of some reflections and considerations to kind of enable all of us to discuss this together. Just want to highlight from these discussions to tie together. One is to highlight this myth of model minority, especially for the Asian population. There's this cultural concept of model minority in North America, that Asians are a minority race, but they don't really need extra help, unlike other minoritized groups, because they're well educated, everything should be fine, they make lots of money, they're good at math, and all of those stereotypes. So they don't really need help. But time and again, in the Asian community, we call it the myth, because that's a myth that's kind of propagated. It's not true when you look at stats for everything. In terms, there's still lots of different areas of health disparities. And those health disparities, we need to kind of, once we have the data, we need to understand it more to truly have the kind of equity for Asians. And the second, from a cultural kind of psychiatrist point of view, of course, culture is heterogeneous. So as we're reading the data, reading the quotes, you can see the quotes. It says sometimes born in Canada or Canadian born. And you can know that people from like the different kind of locations, if they speak Cantonese, if they're from Hong Kong, or they're from Guangdong, from China, or if they're from mainland China speaking Mandarin, or they're Mandarin speaking, but from Taiwan, there is heterogeneity within a culture as well. And so there's also a broad and narrow look at culture. And there's a look at culture, whether you're looking at the country of origin, but also are they from a Chinese church group versus Chinese Buddhist temple, right? So those are also representing different culture. And then this other thing, when we talk about cultural differences, first of all, sometimes we're uneasy about talking about culture, and the other is the blind spot that culture only exists in the other. So both things can occur. So as we're listening to these, we might say, well, it applies to all culture anyways, this kind of family shame, but yes and no, because it's kind of interpreted through a cultural lens. The meaning-making process is different. And then the other thing is to say, well, how come, there are these problems caused by Chinese culture? And in that way, it's just simply a lens where sometimes we think that white Caucasian, as you can see that line, is the baseline where there is no culture. And then culture causes problems because other cultures exist, whereas white culture is considered no culture. I've run a number of cultural competence workshops. Sometimes the first thing a white participant might say is, to describe your culture, a white person might say, but we have no culture. We just do things normally. And then there are these cultural groups who do things abnormally or culturally. So I think that I'm exaggerating a little bit how people speak, but that's what is kind of heard by minoritized races. And I would kind of touch upon this point, which is when we present these findings, sometimes we get pushback from cultural groups because it can come off as saying that this is how your culture deviates from the norm when there's no culture. So when we look at a graph, this is the norm, and this is how Chinese people, because of Chinese culture, are different. So the culture is the problem. So we have to be really careful in the way we discuss cultural differences. So both not and decide that there is no difference, to decide that, okay, culture is a problem because Chinese people have a culture, and there lies the problem, Chinese culture. Whereas the way we see things is, this is how we do things. It is embedded in an implied, you can say, North American culture. So there's a fluidity of culture, obviously, the time. So the different generations going to think differently, the place we talked about, but also differences of acculturation, whether we're interviewing an old lady versus kind of a younger generation. And there's also, as I said, other contextual factors. If they feel that the interviewer is a young generation researcher, they're going to answer differently from an older person talking with them. Sometimes it's to that degree for the older generation. They would say, oh, young researcher, what do you know? Right? And there's a concept of intersectionality. So we just briefly touch on it. So Chinese men different from Chinese women, old versus young. Religion and sexuality, everything of it. Also, there's intersecting way of perception, but also the experiences. And culture exists on a micro, meso, and macro level. So when we think about this, we can then, which is getting to the kind of last couple of points, then we can think about how culture manifests itself is in this kind of one-to-one between the person and the researcher, but also between you as a healthcare provider, as a doctor, as a social worker, as a nurse, and the person. There's a kind of cultural exchange, but there's also the program when they walk into UHN, when they walk into like the kidney department, and that there's also macro societal issues, right, out there in the community, both in the Chinese community, but in the mainstream community. So we can see culture existing. So when we look at how to address these health disparities, putting everything together, we can look at the importance of culture. That is not like it's a nice and optional bonus thing to consider, but how does it really integrate? How does it truly important as the cornerstone? So it's not like the dessert after the main menu. For a lot of minoritized races, culture is the main course, because sometimes in most healthcare system, sometimes we think that that's the kind of the cherry on the cake is, okay, let's kind of throw in a little bit of culture at the end would be nice. But what we can see from the data is for many minoritized groups, culture is the main course. It is not like if we have extra funding, let's also throw in some nice kind of cultural symbol, and then that would be the kind of cherry on the cake. So how do we then move towards cultural competence and safety? I think we can look at the W5H, and that itself can be like an hour of who, as we heard, like who are the messengers, who needs to be the, how do we tailor the message, and what the message ought to be? How does it come from a source of positivity versus negativity? And how do we make change both in an individual level? And that means as a clinician, when we are one with the patient, how do we have this engagement that's more effective to at a systemic level as kind of like a transplant program? How do we do better as at a programmatic level? So that becomes the different levels of consideration. And so just going to end on this slide then for general discussion, inviting everyone to kind of think about and contribute, is then how do kidney health providers, how can we incorporate the importance then of family and the culture into kidney health education, and to raise awareness about living donor kidney transplantation. And from all this talk, and you reflect on your practice, how do you feel you might change like in your practice? And then together, collectively, how do we advocate for change at a systems level? So I think that these are the questions that our team has kind of brought forth with you. Maybe I could end there and pass it back to Istvan to moderate.
Thank you very much. Thank you, Cindy, and thank you, Ken, for this thought-provoking, very insightful presentation. I really would like to just come back to that notion that Ken made about how culture is ever permeating of every step of ours and for every one of us. And this notion of white European or white North American individual thinking that, well, we have no special culture, we are the ones everybody needs to be related to. I think it is central, and it's reminded me, Dr. Carl James, who's a sociologist at York, and he's one of our collaborators on our African Caribbean Black Studies. His book entitled Seeing Ourselves also writes about this, and this is the topic, that actually most of his students who were whites, they were puzzled that why would they be asked about their own culture, whereas culture relates to others. Whereas when you see a patient in whatever setting, it is important to see the dynamic of all the cultures that are present in that room, and that needs to be considered in our care. And I hope that Ken's experience with cultural psychiatry, both in Canada and internationally, can inform how we try to create something, a culture more responsive, more competent transplant program to serve the very diverse patient population here. Thank you very much for everybody. Thank you.